So I am going to talk to you today about monoclonal antibody treatment in CLL. I'm both a doctor as well as a scientist. So I would like to tell you about what we've been doing at Southampton and how it fits into the whole story about what we were doing previously and currently and what the future holds, essentially. Okay, so starting very in a basic way, these are plasma cells, are immune cells in our, we all have it. They are normal immune cells in our healthy body, and essentially they secrete antibodies. And antibodies fight infection normally. And the antibody is, if you think of it as a Y-shaped molecule, you have your hands here, and your hands, they grab onto the cancer cell. They recognize tags on the cancer cell. They grab onto the cancer cell. And your legs, they hook onto the immune system. And by that, they kind of essentially are able to attract the immune system to the invader and then get the immune system to recognize and kill the invader. So what's so special about monoclonal antibodies? Well, chemotherapy is not specific. Chemotherapy works by getting into the DNA, getting into the nucleus of rapidly dividing cells, which is why when we treat someone with chemotherapy, we see side effects like hair loss, because hair follicles are rapidly dividing. We get mouth sores. Again, these are all cells that are rapidly dividing. Whereas monoclonal antibodies are what we call magic bullets. They are specific. These hands, they recognize, specific tags. And if we can identify tags that are just found on cancer cells, then these antibodies will just attract the immune system to the cancer cell. And that's what makes it so magical. So the two really relevant antibodies in CLL today really are the anti-CD20 monoclonal antibodies. And essentially, this means that the tag that they grab onto is a protein called CD20, and it's only found on B cells, and which I'm sure you've all heard today that CLL is a cancer of the B cell. So rituximab was one of the first few treatments that entered into clinic. I won't go into too much detail, but it was originally approved by the US FDA back in 1997, and now more recently we have another different type of anti-CD20 monoclonal antibody called obinutuzimab, which has just recently been approved. And these antibodies are used in combination with chemotherapy now in frontline treatment in CLL. So just to give you an idea of exactly how significant, what is the impact from the introduction of monoclonal antibodies in cancers. You see here I have a graph essentially on the y-axis is kind of the rate of death per 100,000. And on the x-axis, we have the time points going from 1975 up to 2005. And at the top on the arrows here, these are all different chemotherapy agents. And what you see here essentially that despite the fact that there'd been new chemotherapy agents being developed, and also that we were combining all kinds of chemotherapy agents, we really weren't doing very much in trying to reduce the mortality rate from non-Hodgkin's lymphoma, B-cell cancers in the most part, until the approval of the anti-CD20 monoclonal antibody rituximab came in 1997. I'm not saying that all this fall in death rate is only due to rituximab. There's probably better support, better care, and lots of other things, but it certainly has played a role in improving the response rates from the diseases. So this is one of the first few trials. Essentially, what you're looking at is a survival curve. This is the proportion of patients in the trial that was free from complications of the CLL, and there were over 500 patients in this international study where they compared two chemotherapy agents, fludarabine and cyclophosphamide, which is the yellow line, with the addition of rituximab to the same agents. And what you see here, essentially, at the time point 0, there is 100% survival or kind of free of complications, and as time goes on, there kind of more problems occur. But you can see here that when we add in rituximab, there's certainly a difference. But the question that we are interested as a researcher is, why isn't it better? You can see that essentially, even though adding rituximab to chemotherapy makes a difference and reduces the kind of complication rate, really, we can do a lot better. And what we're interested in the lab at Southampton, and also a lot of researchers around the world, is how can we make rituximab better? How can we, get more essentially increase the kind of response rates? And to really know how we might do this, we first of all need to understand how rituximab works. So I've got a cartoon here. This is, if you can imagine, the cancer cell or the CLL cell. It expresses the protein CD20. So in comes the antibody. Like I said, the arms grab on to CD20, and this region of the antibody, the legs, is called the FC region. And basically, that grabs on to, that kind of hooks onto FC receptors that are on macrophages, which are natural cancer-killing kind of immune cells in our body. They don't just kill cancer, they kill lots of other, like bacteria as well. But the point being that by this happening, the antibody is able to act as a middleman and attracts the macrophages, which then essentially swallows the cancer cell and then digests it. But you can see here that this molecule, the FC receptor, on the cancer killer cell, on the macrophage, is really important because it kind of, the legs of the antibody hooks onto it, so it needs to be the right type of receptor. So I'm going to delve into a bit of science now. And so what are FC receptors? It's really kind of simple in the sense that these receptors are expressed on many types of immune cells in our body. And there are ones that are activatory and ones that are inhibitory. There's only one that is inhibitory, and the name of this receptor is called FCR2b. All you need to know essentially is that the antibody's legs hooks onto an activatory receptor. It increases the clearance of tumor cells. It helps the macrophage, it kind of raises, essentially makes the macrophage more active, and then the macrophage goes on to kill the tumor cell. Whereas if the legs hooks onto an inhibitory FC receptor, or called FCR2b, then it kind of it dampens down the activity or reduces the ability of the macrophage to be able to kill the tumor cell. So like I said, we were interested in finding out why the response rates to rituximab wasn't as good as it should be. And to study this, what we did was we incubated some cells that we got from healthy volunteers, in this case, people that worked in the lab, or my husband in this case, and patients, patients with CLL. So each of these dot represents a different individual. The sample, the cells are stored, frozen in a tumor bank. We thaw them, and this is what we do with them, or part of it. And other patients with other types of lymphoma. And what we've done here is we have treated these patients' blood with the antibody rituximab for 6 hours, and then we looked essentially to see how much antibody was left on the surface of the cell. And this y-axis tells you essentially that gives you the surface accessible levels of so how much antibody there is left on the surface essentially. So for instance, you will find that some cells on some cells, there was very little rituximab left on the surface, which meant this rituximab was internalized into the cell, whereas others less so. And what we realized that cancer cells all seem to internalize rituximab at a very heterogeneous rate, whereas normal cells, or cells from normal healthy adults, internalize rituximab at a very consistent rate. So we thought, could this be responsible for the differences that we were seeing in response? And when we looked at the levels of the inhibitory FC receptor I was talking about on the tumor cells, we found that there was a nice correlation between the levels of internalization of rituximab and the levels of in the inhibitory receptor, meaning the higher the levels of the inhibitory receptor, the more internalization there was. So just as a summary of what's happening, here is what I've said happens here. Here's our antibody. Here's what we would like to happen, as in the antibody acting as a middleman between the tumor cell and the macrophage, our immune system. But in fact, that's not what happens. See, the antibody instead, the FC domain of the antibody binds to inhibitory receptor on the cancer cell itself. And then the whole complex is then swallowed into the cancer cell, internalization. And this means when this happens, essentially, the antibody is no longer on the outside of the cell to say, help, help, I'm a cancer cell. It can't pull in the immune system to recognize the cancer cell. And what happens is then the cancer cell then degrades the antibody, and there we have resistance to treatment. So when we, there are many different types of antibodies to CD20, as I said earlier. There is rituximab and there's obinutuzimab. There is actually a whole lot of other antibodies as well. Since the approval of rituximab and we know how it worked, there's been a lot of excitement in the field. And the difference is that all these antibodies, they differ in that they recognize different parts of the CD20 protein. The lab in Southampton, led by Mark Craig and Martin Glennie, have done a lot of work in trying to understand the differences between these antibodies. So what we did was we wondered how did the other anti-CD20 monoclonal antibodies compare to rituximab. And when we did the same internalization assay, as in incubated cells from healthy individuals or from patients, and with the antibody for 6 hours, and then examined to see how much antibody was left on the surface of the cell, we found that obinutuzimab internalized less than rituximab. So still not as good as the normal cell. There's still a lot of heterogeneity, but it certainly appeared to be much better than rituximab. Now, this is certainly very good. All the experiments so far we've performed, they've been in a test tube, but real life is a lot more complicating, and we always need to complement our work in test tubes in vitro with in vivo investigations in the body. And in this situation, obviously the most accessible, we used mice. And what we've done essentially is that we had antibodies that have been produced in the lab and that are like rituximab and like obinutuzimab. So these antibodies bind to mouse CD20. So we injected mice with a single shot of the antibody and then measured the levels of B cells on these mice. So B cells express CD20. We would expect the antibody to be able to clear the mouse of B cells. And here we have the control. You can see that if we put in an antibody that doesn't bind to CD20, it doesn't do very much at all to the circulating B cells. When we put in rituximab, you can see these are just two different mice. You can see that it's very good at depleting rituximab, but then the levels of B cell then comes back up again. But when we give obinutuzimab, it's significantly more effective at depleting the B cells. So in essence, what we see in the test tube is matched by what we see in vivo, and we were pleased with these results. But obviously, more importantly, is what happens in humans. And this is a kind of an update of again, a large study in which over 700 patients took part. This is an international study where they compared obinutuzimab with an oral chemotherapy agent called chlorambucil versus the combination of the old antibody, rituximab, and chlorambucil. So you can see here that, again, this is a survival curve with the time going from 0 to 48 months, and this is the kind of survival rate. And what you see that if the patient is being treated, patients that were treated with obinutuzimab and chlorambucil did better, had less complications than patients that were being treated with rituximab and chlorambucil. So again, superior and consistent what we believed in the lab. So obinutuzimab certainly appears better. Sorry, there's a typo there. But it's still, I showed you that it's still subject. The antibody still gets internalized. And if a tumor cell has really high levels of this inhibitory receptor FcRn2b on it, then the disease might still not respond. So how can we make it even better? How can we improve upon obinutuzimab? And we had an idea. We thought we can block FcRn2b. And this was still is our hypothesis. Again, we have the CD20 on the tumor cell. We have the antibody in which the Fc region binds to the inhibitory receptor on the tumor cell. Therefore, it's not free to engage the immune effector cell. We can block it. If we block this inhibitory Fc receptor with another specific monoclonal antibody, an anti-FcRn2b antibody, then that receptor would be occupied and the monoclonal antibody would not be able to bind to this one. And by doing that, we hope then it would be free to engage the activatory Fc receptors on the cancer-killing macrophage cell. So we went on to test this. I mean, I'm kind of slightly simplifying it in a sense that when we first started doing this work, I have to say that there were no antibodies directed at FcRn2b, and a lot of work has gone into interim. There's been a collaboration with a company called BioInvent to produce and design these antibodies. And what essentially we did was then, once we have had these specific antibodies, I show you here the results of a phagocytosis assay. So an assay whereby we're testing the ability of the macrophage to swallow and degrade a cancer cell. So here, what we've done is we have samples, again, from patients who have CLL. So there's 1, 2, 3 patients, and we have, again, these cells are treated with rituximab and a control antibody, which does not bind to FcRn2b. And then the red bars, you see rituximab with an antibody blocking FcRn2b. And basically, when we incubate the samples with the antibody, and I should take one step back. So what we've also done is that we've also harvested, so we've also got cells from healthy donors, and we have produced macrophages in the lab. So we've put these macrophages with a cancer cell, and then with either rituximab and the control antibody, or rituximab and this blocking antibody. And the y-axis tells you the level of phagocytosis, the level of ingestion of the tumor cell by the macrophages. The higher, the better. And you can see that in all 3 cases, when we block FcRn2b with the second antibody, there is more killing of the cancer cells. And this is what we see down the microscope. So in red here, we have a macrophage, and in bright green here, we have the labeled cancer cells. And essentially, what you see here are all the cancer cells within a macrophage. So, right, I'm even going to do better than that. I'm going to show you a movie of what happens. So this is a time lapse. So what we've done is we've taken the tumor, we've taken the healthy human cells. We have kind of generated macrophages like we have in the body out of them. We put them in a dish, and then we have labeled the cancer cells with this bright green dye. And we've got rituximab in here. So all these long spindly cells are the macrophages, and all these little dots are CLL cells specifically. And it's going to be really busy, but I want you to concentrate on this area, and I'll show it to you. And movies never always, they always kind of not work. Okay, let's try this. Okay, so here we go. You can see here, so if you concentrate, for instance, on these areas, you can see these macrophages engulfing and taking up and breaking down, essentially, the cancer cell. The green is disappearing. And what happens is all these processes, the cells just go in, they get ingested, they get transferred to the middle of the body, and then essentially, it's slowly, the one macrophage just keeps killing all the cancer cells. But you can see here also, there are other macrophages which aren't the same shape. So even though they're macrophages, they're not doing any killing. And another part of our research is trying to understand why exactly are some macrophages so good at killing, whereas others aren't as good. So the take-home message, or kind of the points that I'm trying to make, is that monoclonal antibody therapy has really added onto our treatment of CLL, improved the responses that we get from chemotherapy. Obinutuzimab appears to be better than rituximab because it doesn't internalize. I have to say that there are probably other mechanisms by which these cancer cells are also resistant to treatment. This is definitely, we think, one of them. And it's really exciting that now that we've taken the research all the way from bench into clinic, now with kind of working together with this company, we're going to be testing the combination of rituximab and this FcR2b blocking antibody in phase 1 human trials later this year, led by Dr. Andrew Davis at Southampton. So that's the end of my talk. I'd like to thank everyone. So thank all of you, patients, and everyone who's going to take part in the trials, gives us cells to work with. This is some of the research that we do with it. None of this is possible if you aren't there to give us the material. And our tumor bank staff, research team, there are a lot of investigators, clinicians, and scientists that are involved. A lot of the work you see was done in the antibody vaccine group at Southampton. There are 6 kind of distinct groups within us, and we all work very closely together. And obviously, nothing's possible without funding. And Cancer Research UK have been very generous and Bloodwise as well. Thank you very much.